My name is Heidi Shaw. I'm a registered nurse at the University of Utah Hospital. I work in the transplant department as a transplant coordinator. Today we're going to be talking about the options of renal transplant. Picture of the front of the University of Utah Hospital. So we're going to get right into the demographics of chronic kidney disease. So there's 350,000 patients that receive maintenance dialysis in the U.S. today. About 484 of those patients are in stage 4 kidney disease. So much like other organ diseases, kidney disease comes in stages 1 through 5. Typically, you do not seek treatment for your kidney disease or have signs and symptoms until you're in stage 4. There is also about 85,000 patients that are currently waiting for a kidney transplant. So, chronic kidney disease options. We consider renal transplant an option because it's not a cure to your kidney disease. It's one of the treatment options much like hemodialysis and peritoneal dialysis are a treatment option for you. Unfortunately, if you choose none of these three, the hemodialysis, peritoneal dialysis, or renal transplant, death will occur. Because renal transplant is an option, you may refuse transplant as one of your options. If you feel like one of the risks outweigh the benefits to you for transplant, then you may refuse. In turn, if we feel that the risks outweigh the benefits for you, or if we feel that your quality of life will not be improved with transplant, then we may refuse transplant for you. So we've got some advantages and disadvantages for transplant. Some of the advantages would be the survival advantage, the quality of life. Our main goal is to improve your quality of life, be able to get you off that dialysis that you have weekly or daily, and be able to get you to maybe be able to travel, vacation, maybe go back to work if you're not working, be able to exercise, those kinds of things. So that's a huge thing for us that our whole goal is to improve your quality of life with transplant. Other things, fluid and blood pressure management gets corrected with transplant oftentimes. Correction of your electrolytes. Many of you may be watching your potassium, your calcium, your phosphorus while you're on dialysis or during your kidney failure, and that gets corrected with your transplant. Also, you have no fluid restriction after you're transplanted. You have minimal diet restrictions. In fact, a lot of the diet restrictions that you have are related to the medications and not to your kidney disease. Another advantage would be the long-term cost savings. So disadvantages. The disadvantages would be medications. We start you on some medications that are called immunosuppressant medications. What those immunosuppressant medications do is they trick your body into accepting the new kidney as its own. Unfortunately, when your body receives these, you are also more susceptible to being a high risk for infection, viruses, or even some cancers. Another disadvantage to the medication is the medication is required for the life of the kidney. So you'll be taking that daily, and some would consider that to be a disadvantage. Time on the wait list might be a disadvantage. Sometimes it's frustrating to wait for a kidney to become available to you. Being retransplanted is also a disadvantage. Kidney transplant does not last forever. They are typically deceased donor transplant will last around 10 to 12 years, while the living donor transplant 12 to 15 years. And we'll talk a little bit about why that is in a few moments. Other disadvantages could be disease reoccurrence, complications to the surgery, and then the larger upfront cost could also be a disadvantage. So indication for transplant. Your kidney function needs to be less than 20%, or you need to be on dialysis. Also, you need to be healthy. Unlike many other organ failures, kidney transplant recipients need to be healthy, including no current infections. So we have some contraindications for kidney transplant. We have absolute contraindications, something that we typically will decide early on if you're a candidate for transplant, and then we have relative contraindications. So absolute contraindications would be something like recurrent cancers, recent or current cancer, excuse me, severe heart, liver, and lung disease, severe blood vessels in the leg, disease in the legs. That is because we put the kidney in your lower abdomen and we tie it to the vessels that go down to your legs. If you have poor circulation in your legs, then your new kidney is not going to get the circulation that it needs in order to be able to survive. Non-compliance, that is a contraindication. We look at that very closely when we deal with kidney transplant. It's important that you're making your appointments, that you're taking your medications currently, that you're doing your dialysis. Those kinds of things are very important because receiving a kidney is a gift, and we want you to take care of that gift as, and that's one of the things that we'll be able to tell if you'll take care of that kidney is if you're compliant with your regimen right now. Being overweight is a contraindication. We need your BMI to be less than 35. And then smoking. You need to be smoke-free for 3 months before you have an appointment to see us, and then not smoke thereafter. So some relative contraindications. Something that maybe we look at, and we look at on an individual basis, and make sure that they are either absolute contraindications or we're going to be able to transplant you. So depending on drug and alcohol abuse, maybe some chronic diseases of other organs might be an issue. Age is a factor oftentimes, hepatitis B and C, and then multiple failed transplants, typically more than 4, and are something that we have to look at closely. So your evaluation, you feel like you're ready to have a transplant, and so what you do from then on. So you have a referral from your nephrologist is the first step. Then you complete your health maintenance exams, and you get a history and physical here at our facility. We do blood typing. We do and then we do antigen and antibody testing. Those three, the blood typing, the antigen, and the antibody testing, is for us to be able to find the right match for you, the best kidney for you based on your blood. We do routine blood and urine testing. We check for viruses and immunity against childhood diseases. When you come to the clinic, we also do an EKG and a chest x-ray. We do a bladder scan to make sure that your bladder is emptying correctly, and then we also check for TB. So all those things are done during your clinic visit. Typically your clinic visit is several hours long in order to get this process complete. So those health maintenance tests that we talked about, dental and echocardiogram, everyone has to have that. If you are a female older than 18 years old, you'll need to have a pap smear. If you're a female older than 39, you need to have a mammogram. If you are older than 49 years old, we require a colonoscopy. Stress test is required if you're over 55 or if you have diabetes. An eye exam if you're diabetic is also required, and then a prostate exam for males that are over 49. So those are the testing that you need to have done prior to coming to clinic to be evaluated for a transplant. So the blood typing. It's not as important that you match your blood type, it's important that you're compatible. So compatibility would be O can only receive from O. However, A can receive from an O or an A B can receive from an O or a B, AB can receive any blood type, and the RH factor, the negative positive that's behind your letter, so if you're an A positive or an A negative, that is not recognized in kidney tissue and is not a factor when we match your blood with others. Vaccinations. So vaccinations are recommended but not required. In fact, they're highly recommended. Once we give you the immunosuppressant medication that lends you to more infection or being more susceptible to viruses and illness, having your immunizations already on board before you take those medications will help prevent some illness after your transplant. So these are some of the vaccinations that we recommend. Your hepatitis A and B, your MMR, tetanus every 5 years, the flu shot every year, the pneumonia vax every 5 to 10 years, your chickenpox if you're not immune to that, Gardasil, that's for cervical cancer, so we only give that to females that are under 27 years old, and then the Zostavax, which is for shingles, and that is for patients over 50. So kidney source, where are you going to get your kidney? There's 4 options. So you've got the living and deceased donor kidney. We'll talk about those in more detail. Anonymous donor. Anonymous donor is where someone will come to the hospital and say, I would like to donate a kidney to your wait list. That happens several times a year, and it's quite a gift when that occurs. Paired donor exchange. Paired donor exchange is where you have a donor, a live donor, that would like to donate to you, but your blood is not compatible with that person. So let's say I also have a donor that is not compatible with my blood type, and we swap donors. So my donor gives to you and your donor gives to me. That chain is a nationwide program, and those chains can be up to 20 patients long, and so that's been a beneficial program that we offer here. So live donor transplant is when someone that you know, a friend or a relative, would like to give you a kidney transplant. There are some advantages and disadvantages to live donor transplant. The biggest advantage would be the shorter cold time. So cold time is the time that the blood supply is cut off to the kidney from the donor and then replaced into the recipient. And sometimes that lends to better outcomes and functions earlier on. So that's when we were talking about the term that the deceased donor lasts a little bit less time than the recipient, and that's mainly because of cold time. Typically that cold time can be cut in half, or maybe even a quarter of the time if you have a live donor. Another advantage would be avoiding the wait list and being able to schedule when you're at your own convenience. Maybe you're a school teacher, would like to schedule during the summer, or you're a farmer and you'd like to schedule when your harvest is done. And then the emotional gain to the donor is always a benefit with live donor transplant. So some disadvantages to live donor transplant. There can be a psychological stress to the donor and the family, particularly if let's say I would like to donate an organ and maybe one of my family members is not comfortable with it. They can cause some psychological stress that we need to work through. Inconvenience during the evaluation, possible complications from the surgery, and then maybe some possible complications later in life, like protein in the urine or hypertension. Requirements for a live donor. Live donors need to be between the ages of 18 and 65. They must not have high blood pressure off of medications. Their blood pressure needs to be less than 140/90. They must not have had diabetes or cancer. They cannot become pregnant or have been pregnant within the last year. They cannot be overweight. Their BMI needs to be less than 31. They cannot have multiple risk factors for heart and lung disease, no kidney disease or infectious disease. They need to be able to be off work for 4 to 8 weeks. They need to agree to the test and procedures that we need to do in order to see if they qualify to become a donor. They need to be able to afford their transportation and the cost of being local here in Salt Lake. And so once the transplant occurs, then we bill the recipient's insurance for that. So the testing is at no cost to the donor, except for their health maintenance testing. That was something that they need to be able to do on their own. And then once that's complete, everything else is billed to the recipient's insurance. So deceased donor transplant. The majority of solid organ transplant donors have met an untimely death. Most of them are a brain injury, a anoxic brain injury such as a lack of oxygen to the brain. Some are motor vehicle accidents where maybe they've had head trauma, but they haven't had abdominal trauma that would maybe injure the kidneys. Or sometimes they've even had a tumor that has not spread. They are kept alive on life support until their organs can be removed once they have decided that transplant is for them, donation is for them. So your procedure, once you get to the point of transplantation, your procedure is going to be 3 to 4 hours long. Your incision, like we had talked about, in your lower abdomen, 8 to 10 inches long. You'll start anti-rejection medication right away. Typically that medication is started in the operating room sometimes. You'll go to the intensive care for 1 to 2 days, and then you go to the regular standard surgical floor for 4 to 5 days. So you'll be in the hospital for a solid week when you receive your transplant. You may require dialysis for a few days, so we can plan that as well. So here's a diagram of what I was explaining. So you've got your kidneys up on top. Here, typically they're left in. Your native kidneys are left in unless there's a reason to remove them. And then we transplant your kidney on the lower, and you can see there the vessels tie in, the kidney gets tied into the vessels that also feed your legs, and that's why it's so important for you to have good blood flow. So complications that can occur during your surgery. There's the bleeding and blood clots. There's some urine leaks can happen, obstruction, rejection. You can get infections anytime you have surgery. Those kinds of things are a risk. Fluid collection around your kidney, side effects to the medication, and then death can occur anytime you're dealing with anesthesia or things like that. So we'll talk about the rejection. The rejection is the major cause of transplant loss. We have acute rejection and chronic rejection. Acute rejection usually occurs within the first year and is typically reversible. So that's why we have you seen so much in the first year. That's why we draw your blood so often in the first year, is because typically we can assess for a rejection. If we find it, then we would be able to get that cleared up for you quickly. After the first year, chronic rejection sets in and sometimes can last many years after that. So chronic rejection is 30% of chronic rejection is due to that non-compliance we were talking about earlier, where you're not taking your medications, maybe you're not following up with your doctor's visits, those kinds of things. And so it's definitely a high percentage that you could lose your kidney due to non-compliance. Other things that can cause chronic rejection would be maybe recurrence of your disease or other things like renal artery stenosis or obstruction. So the wait list. Once you have come to our clinic and you have been approved to be placed on the wait list, the deceased donor wait list, the wait list is governed by the United Network for Organ Sharing. They actually facilitate the matching of donors with recipients. They ensure that all centers follow the same rules. They make it so that you can transfer your time and that you can be listed at multiple centers at one time. They also have contact information, which is very important because you not only have us to contact as a transplant department, but you also have them as a backup if you have any further questions or need further information. So there is a point system that works with the transplant wait list. So typically a wait list would feel like an actual list, but in this circumstance, the wait list is not a list. It is actually a pool of people. The pool of people so you're sitting in that pool of people with your blood type, your antigens and antibodies attached to you, along with these points. Points are given for time on the wait list. They're given for how well you match with the donor. And then they're also given for having high antibodies. So when a donor becomes available is when the list is created. The list will be created based on that donor and the donor's blood type, antigens, and antibodies. And once that donor's organs have been transplanted, you go back into the pool of people until another donor becomes available. Once another donor becomes available, a brand new list is created based on that donor's blood type and so forth. So that's how the wait system works. Pediatric patients get priority on that wait list, as does prior kidney donors. They also get priority. So if you've been a donor and you now are in kidney failure, you get priority on the wait list once you go through the evaluation process. So when will you be listed? You come to the clinic here, you're evaluated, you do all the testing that you need to do, and all of that is complete. We present you to the committee, and we determine that you are able to be placed on the deceased donor wait list. After that, we'll need to get a financial authorization, and then we call you and send you information by mail to let you know you've been listed. Until that point, you are still in the evaluation phase. So once we list you, you have your wait times. Wait times are for an O here at the University Hospital is 2 years. Nationally is 4. A is 1 year, and nationally is about 2.5 right now. B blood type for the university is 2 years, nationally is about 3.5, and then AB is about 9 months, and nationally is 2 years. So there's your wait time. If you have any questions about the transplant program here at the University of Utah, please do not hesitate to contact myself or Doug Osler. We are both transplant coordinators here and would be happy to answer any questions that you might have. Thanks so much.